Good afternoon to all of you. You are more involved in everything. So let's start without wasting any time. I'll only discuss part of surgery. I'll not discuss liver, gallbladder, pancreas. That will be covered by Dr. Gaurav in the next session. So you see, the trend has completely changed. I'll just take 2 minutes, then we'll start. Earlier, we used to have one-liners, like commonest cause of this, rarest cause of this. And still, many teaching is the same way. But that's not the question you get. Questions are totally different. Questions are now concept-based and approach-based. So the trend has, and there's no repeat question. Don't just rely on MCQs. You have to have your concept clear. You have to read the theory part. So what I've included here is more of image-based thing. Now you are getting more image-based and approach-based. So in hernia, like what we used to discuss earlier, direct and indirect differences and, other classification or Gilbert classification, they don't ask that now. They ask more of laparoscopic approach. So I've included some part of hernia which are the new concept. One is the Nahes classification. It's somewhat important and off and on you get question from this. You see, one very minor point you have to know. Whenever we say there's a defect in the posterior wall or the fascia is weak, means we are talking of direct hernia. And when we say internal ring is wide, means we are talking of indirect hernia. So in classification, we don't say direct, indirect. We say posterior wall weak and internal ring wide, okay? So you see, there are 4 types of hernia. Nice classification, type 1, 3, 4. 4 is not important, it's just a recurrent hernia. Type 1 and 2, both are indirect hernia. What's the difference? In type 1, it's an indirect hernia with a normal internal ring, and type 2 is an indirect hernia with a wide internal ring. Type 1 actually is a congenital hernia, which I've written later on. Type 3, there are 3 types, A, B, and C. A is a pure direct hernia. B is a direct and indirect hernia. Means pure direct hernia, I will say as posterior wall weak and internal ring normal. B is direct, indirect, so posterior wall weak and indirect and internal ring is wide. So B is called pantaloon hernia. When we have A and B both, direct and indirect both, it's called pantaloon. This is MCQ. So remember, type 3B is a pantaloon hernia. Okay, right. And type 3C is femoral hernia. As far as type 4 is concerned, it's just a recurrent hernia, A, B, C, and D. A is a direct hernia, B is an indirect hernia, C is femoral, and D is combined. Now, this is what you have to remember, only this part. These are the MCQs. Congenital inguinal hernia is type 1, pantaloon hernia is 3B, and femoral hernia is 3C. This is what they have asked. This has been asked earlier also. So Nahes, just to revise, there are 3 main types. 4 is recurrent, we can skip that. So 1 is an indirect hernia with normal internal ring. Also congenital hernia is type 1. 2 is an indirect hernia. Obviously the posterior wall here will be normal. I told you posterior wall is for direct hernia. Fascia transversalis is for direct hernia. Okay. So posterior wall will be normal in 1 and 2 both. 1 is congenital, 2 is the internal ring wide. 3A is only direct hernia where the posterior wall is weak. B is direct, indirect, both pantaloon hernia, posterior wall weak and internal ring wide. And C is femoral hernia. Okay, so this classification you have to remember. This is in hernia, now it has become important. Let's understand triangle of doom. Let's first understand what we are looking at. We are looking at the inguinal area from inside, okay, not from outside. In hernia, we discussed from outside. This is a laparoscopic view from inside. Just to give you some idea, this is the right side, it's not left side, we're looking from inside. So this is ASIS here, and this is the inguinal ligament, this is the lacunar ligament here, okay? So inguinal ligament, internal ring, Hasselbalch's triangle, indirect hernia here, direct hernia here, femoral hernia here. We are looking from inside, okay? This is the area here, this area. This area we have to cover in laparoscopic hernia surgery. Although we put a mesh, big mesh, but we don't dissect here and here. This area is very dangerous. As you can see, 2 vessels here. This is called triangle of doom in laparoscopic hernia. This is called triangle of pain in laparoscopic hernia. Here all nerves are there, here vessels are there. So we just dissect the whole area, but only put tackers or anchors or sutures here. Don't do any major dissection or fixation here. This will cause bleeding, this will cause pain. So the boundary of triangle of doom is this. This is right side. This is the femoral ring, indirect ring, direct ring. So this is the vas deferens. This is testicular artery and this is peritoneum covering the psoas. This triangle is called triangle of doom. This should never be, don't do very extensive surgery here or fixation here. Okay? So what are the boundary? Medially, vas deferens, as you can see here. This is the vas deferens. Laterally, vessels to, this is the testicular artery. You can simply write testicular artery. And then third one is the peritoneum. As you can see, here, this will be the peritoneum. What are the content? The contents are external iliac artery and vein, number one. This you can leave. Genital branch of femoral nerve and femoral nerve you can see here. Femoral nerve comes in both the triangle. So these two are very important and genital branch of femoral nerve. This triangle here is called triangle of pain. We have nerves here. Let's see. So again, let's go to this image. The testicular artery, peritoneum and iliopubic tract, this is called triangle of pain in laparoscopic hernia. So testicular artery, peritoneum and iliopubic tract. Inguinal ligament from inside is called iliopubic tract. So this is triangle of pain. We have 4 nerves here. You should not do any major dissection or fixation here. This is a very important MCQ. So you see, boundaries are iliopubic tract, or we can call it inguinal ligament. This is the peritoneum and this is the testicular artery. And the content from lateral to medial, there are 4 nerves. Lateral cutaneous nerve of thigh here. Anterior division of anterior cutaneous nerve. Femoral branch of genitofemoral and femoral nerve. You see this femoral branch, actually this is the genitofemoral nerve. This will divide. The genital branch will go here. This is the genital branch becoming the content of triangle of doom, and the femoral branch is here. So, I'll tell you 3 lines which you need to remember. These are MCQs. In open appendix surgery, most common nerve injured is iliohypogastric nerve. In open hernia surgery, most common nerve injured is ilioinguinal nerve. And in laparoscopic hernia surgery, most common nerve injured is this one, lateral cutaneous nerve of thigh here. So you have the same thing, same features what you have in pregnancy called myalgia paresthetica, same feature, pain in the lateral part of thigh you will get. So this is all India question. A surgeon doing laparoscopic surgery fixes the mesh inferior and lateral to inguinal ligament, and there's a pain in the lateral part of thigh, which nerve is injured. So I'll repeat what I said. In open hernia surgery, it is the iliohypogastric nerve. In open appendix surgery, in open hernia surgery, ilioinguinal nerve, and in laparoscopic hernia surgery. So this is just a laparoscopic view of the left side. This is the pubic bone here. This is the pubic bone. This is the bladder which is collapsed. This is called cave of Retzius, a space of Retzius, which is retropubic space between the bladder and the pubic bone. Retzius. So this is the Retzius space on left side. This is the vas deferens coming from this side. This is the testicular artery vessels here. And this is triangle of doom. If you go deep, you'll find 2 vessels here. You only fix the area here. This is called myopectineal orifice of Froissart, which of course is AMCQ, which I'll tell you later on. So these are the 4 nerves from lateral to medial that you'll see in triangle of pain. It's left side, the triangle of pain will be here. Lateral cutaneous nerve of thigh, anterior cutaneous nerve, femoral branch of genitofemoral, and femoral nerve. The genital branch, the nerve will divide here, giving 2 branches. Genital branch will come and become a content of triangle of doom, while femoral will remain a triangle of pain content, okay? Both together, triangle of doom and triangle of pain, are called trapezoid of disaster. So triangle of doom for vessel, triangle of pain for nerve, together called trapezoid of disaster. Now this is something like you see here, as I said, we only have to fix this area, strengthen this area, not this area, not this area. Although my mesh will go there, but I'll only strengthen this area. This is called myopectineal orifice of Froissart, which again is an important MCQ. All these are new concept in lap hernia, that's why they become question. So this is the boundary of myopectineal orifice of Froissart. You see this area here, shown by red color, is this is anterior view, not internal view. This is called myopectoral orifice of Fouchard. The boundaries are, you can see rectus here, conjoint tendon here, iliopsoas here, and pubic bone here, pecten pubis here. So the boundaries are superiorly conjoint tendon. This is the left view, this is the right, conjoint tendon. Laterally psoas here, medially rectus muscle here, and inferiorly superior pubic ramus having pectorate ligament. You can call it pecten pubis. So this area is called pen hai? Pen hai? Okay, let me see. Good. Right, so you see, this is the superior boundary, conjoint tendon, this is medial rectus, this is lateral psoas, and this is pecten pubis. So these, and the last point here, you see, last point, in laparoscopic hernia repair, dekho, I have to dissect in this area, I have to fix in this area. This is myopectoral orifice of Fouchard. Normally we don't get any vessel here. It's very bloodless kind of surgery. But sometimes we have an additional vessel here called corona mortis. That again is MCQ. Corona mortis is accessory obturator artery here, which connects inferior epigastric or sometimes external iliac with obturator artery. So if you see this is the obturator artery, you have additional vessel here connecting inferior epigastric with obturator. This is called accessory obturator artery, and this is called corona mortis, seen in 25% of cases. And this also, like here, this one, this artery, it comes in our field now. Otherwise, we don't have any vessel in the area I'm dissecting. So this also can cause bleeding and can cause problem. So this is what is new in hernia. Rest all you know, okay? Now let's come to first X-rays, then surgery, then some minor topic. Dekho, earlier I thought I will show the X-ray and ask what is this, and whoever answer, I'll ask rest of the student to clap for him. But then I realized that almost 90% will you answer. So then you'll end up clapping for each other. So I've changed my strategy. I'll directly tell you what it is, and then we will discuss the topic rather than asking. You can obviously ask some question in between. You can answer if you feel like. So this you see is a minor topic of esophagus where you can see a outpouching here. Here. This outpouching is in cervical esophagus from Killian's dehiscence seen in old person. So Zenker is a protrusion from Killian's dehiscence. And what is Killian's dehiscence? In cervical esophagus, we have thyropharyngeus like this and cricopharyngeus like this. This triangle in between is called Killian's dehiscence. And due to the non-relaxation of cricopharyngeus, we have high pressure there causing pulsion diverticulum. That's called Zenker diverticulum. Common in old, common in males. It's not a condition of young patient, not a condition of children. Much more common in male and much more common in old person. Now this all anatomical deformity of esophagus, barium is investigation of choice. Whether it is stricture, or it is diverticulum, or it is Webb's end ring. All three, barium is in stricture, diverticulum, and Webb's end ring. Barium is investigation of choice. So barium solo you can see. And this I will say is an important X-ray. Some X-ray I'll show which is not as important, but this one is an important X-ray. Treatment is diverticulectomy and cricopharyngomyotomy. Cut the muscle and remove the diverticulum. And we have an endoscopic surgery called Dolman procedure. This was the question of 2019 All India. Question was just one-liner question. What is Dolman procedure is done for what? This is done for Zenker diverticulum. So this is a very minor topic, Zenker. Let's come to next topic. This is called tracheoesophageal fistula, which is a congenital anomaly. In children, esophagus and trachea are not separated. They are connected due to improper separation. The most common type is the upper esophagus closed and lower one connected, which is called type C. There's a fistula between trachea and esophagus. What are the salient points you need to know? Most common type is type C, where proximal atresia, distal fistula. This you have to know. Second point, the first investigation, insert a tube, radio-opaque tube, and take a X-ray, which you can see here. The tube ends up here or gets coiled up here. This distance is 10 centimeter from incisor. This is a very old MCQ, almost 20-year-old MCQ in all India. Tube gets stuck where? It's a line from love and belly, so that's why this becomes MCQ. It gets stuck 10 centimeter from incisor. And once the tube is stuck here, it cannot push it beyond this, or it gets coiled up. You suspect this is a proximal atresia and distal fistula. This is the first investigation we order. Then you can order contrast. In H type, the tube will go in the stomach because H type, type E, there is a connection. You have connection between trachea and esophagus. So type E or H, this is an AIIMS question. Tracheobronchoscopy is most accurate. If you have an option, tracheobronchoscopy and upper GI endoscopy, that is even a better answer. But normally the question they have asked, they did not give two, there were separate options, tracheobronchoscopy and upper GI endoscopy. Among these two, tracheobronchoscopy is a better answer. But if you have an option where both given together, then that's the answer. Tracheobronchoscopy and upper GI endoscopy, that's the best answer. Safest contrast is iohexol. Why it is safest? It is low osmolar and water soluble. Barium is not contraindicated. Barium is more accurate, more radiodense, but iohexol is safest, so we prefer this. And what's the treatment? We decide the fitness of the patient first, only on two parameters. One is weight, second pneumonia. Only two things you see, pneumonia and weight. If the weight is good, no pneumonia, you operate. How you operate? Thoracotomy. Which thoracotomy? Right posterolateral. So we go for right posterolateral thoracotomy and anastomosis. And remember, in GIT, best suture is Vicryl, polyglactin. So always we prefer Vicryl, which is absorbable synthetic, polyglactin. Whenever someone says what is the best suture for GIT, say Vicryl. Vicryl is a market name. It's branded by Ethicon company. So the content is, the composition is polyglactin. So you can remember polyglactin or Vicryl. Both names you should know. Because in exam, they may give Vicryl, or last Sunday, INICT, rather than writing Vicryl, they wrote polyglactin. For bowel, we use polyglactin. So we can do right. And why right? Why not left? Just normally I tell in lectures, for upper esophagus, we have to go from right. From lower, we have to go from left. So if I'm discussing a pathology of lower esophagus, there I'll be doing left. So left, posterolateral thoracotomy for left, and for upper two-third right. So here we go from right because the problem is the upper esophagus. Ligate the fistula anastomosis. And if the child is unfit, like he's sick, he's low birth weight and pneumonia, then we do just gastrostomy. Put a tube in the stomach so that you can feed the child and do the definitive repair later on. This is also an old question of need. The child is sick in TF. What is the first step? Just a tube gastrostomy, temporary tube gastrostomy, and now we'll treat later on. So, whenever he's fit, we feed the child, wait for 1 week, 1 month, it depends. Whenever he's fit, then you go for surgery. So, for a fit child, we do right posterolateral thoracotomy and repair. And for sick children, we do gastrostomy and later on definitive surgery. Type A, this surgery name, I won't say very important, but there is a possibility it may become a question in all India. Fouquet operation is only done for type A, and type A means no fistula, just a pure atresia. There's no fistula, but there's a gap in between. So whenever you have a gap in between, we used to do gastric pull-up or jejunal interposition. Now we simply do Fouquet operation type A. For type A, remember, we do Fouquet operation. So Fouquet is a special surgery only for pure atresia. Another thing that you need to know, it may become an MCQ. Normally we find lots of air in the stomach through the fistula, trachea, fistula, the air comes in the stomach. But in type A and B, the abdomen should be gasless. We cannot push the tube beyond this point, 10 cm from incisor, here or here. So both are TF. What's the difference? This is gasless abdomen, so this should be either type A or type B. Type A is much more important, type A. So if you have a question, then always say type A. Type A is 6-7%, type B is only 2%. So type A and B, we get gasless abdomen. So we cannot push the tube beyond this point. So naturally it's TF. But no air in abdomen, then it's type A and B. And what surgery you do for type A? If I give you this section and say what surgery should be done, then you would say Fokker operation. Okay? For all other, we do thoracotomy and ligate the fistula. Now this is a esophageal web, also called Plummer-Vinson syndrome or Patterson-Kelly syndrome. Now, I'd like to know from you, anyone can answer, in which condition you get this? What is the most common associated pathology? Absolutely correct. As I said, I expect that more than 90% will reply, and this is what happened. So that's why I have not made this discussion question-based, rather I'll tell you. This is seen in iron deficiency anemia. So if you have any question, image-based question, having koilonychia, glossitis, dyspnea on exertion, pale conjunctiva feature, or even a slide of microcytic hypochromic anemia, and with that dysphagia, this will be your answer. Okay, so any feature of iron deficiency anemia with web. Now this web is asymmetrical, right? So this web is asymmetrical and mucosal, means if this is a wall of esophagus, the web will not come here and here. No, it only comes from the anterior wall, mainly. So that's why you see an asymmetrical web. The next topic, Schottky ring, is symmetrical. This is asymmetrical and only mucosal. More common in female in 40s onward. And location-wise, this is post-cricoid. So it is basically seen in the cricopharynx. And this may cause dysphagia called sideropenic dysphagia. Iron is called sideropenic is deficiency. So iron deficiency anemia is called sideropenic anemia, and this is called sideropenic dysphagia. This barium is unlikely to be asked. It may become a question, but I wouldn't say it's a very important barium. But the topic is important. You can have a question on dysphagia with the image of microcytic hypochromic anemia, and then they are asked what it is. It is Plummer-Vinson syndrome. And generally, it has a low risk of cancer, around 2-3%. It is only treated by correction of anemia, unless it's symptomatic. It disappears with correction of anemia. And in case it's symptomatic, then what do? We do balloon dilatation. Never say endoscopic excision, okay? Just put a balloon and dilate. So these are the salient points we need to know about this. Now, esophageal ring, called Schottky ring, also called B ring, just a simple alphabet B ring. What's the difference between this and this? This is in cervical esophagus asymmetrical, while Schottky ring is in the lower esophagus symmetrical. So this is symmetrical, unlike Plummer-Vinson, which is asymmetrical. So this is a symmetrical ring coming from all around, circumferential, and it is found in reflux patient. What is sliding height hernia? This is an image of sliding height hernia. As you can see, G junction and cardia has gone up. This is called sliding. We have a slide on that. So in sliding height hernia, always there's a reflux. Not always, but very often there's reflux. And patient may develop a ring at G junction. So this ring is associated with sliding height hernia. Although it is at G junction, but it will be found above the diaphragm. Why above the diaphragm? Because in sliding height hernia, it has gone in any case above the diaphragm. I mean, the G junction is above the diaphragm. So Schottky ring is a symmetrical mucosal thickening at the GE junction above diaphragm associated with sliding height hernia. This X-ray is unlikely to be asked, but questions are there, theoretical questions are there on Schottky ring. If you ever get a question like this, obviously you cannot diagnose Schottky ring, simply say it's a sliding height hernia. Now, one point you need to know, there is no liquid dysphagia. The liquid dysphagia or 10% patient may remain asymptomatic. So only solid dysphagia. If patient having liquid dysphagia, then Schottky ring is not the cause. And sometimes the food bolus may get stuck here, and that's called Steakhouse syndrome. So Steakhouse syndrome is basically just some causes in which Schottky ring is the most common cause, followed by DES. This is another question. The most common cause of Steakhouse syndrome is Schottky ring, followed by DES, that is diffuse esophageal spasm. What is Steakhouse syndrome? Patient takes a big bolus of meat, although it can happen with anything like orange pith or anything. He did not chew it properly, he swallows it. and the bolus goes here, gets stuck here. So patient has developed sudden aphasia. He cannot eat anything. It's kind of an emergency and you have to do endoscopy and remove. This is not a new thing. This is known for last 70, 80 years. So in UK, in coastal area for sailors, they had steak house, roasted meat. And they used to swallow and the meat gets stuck here. Endoscopy was not there. So they used to give pepsinogen. Whenever the food gets stuck here, meatball, they give papain. And papain, is proteolytic. It makes the meatball more, tender and small and softer. It will pass down. Now we don't go for pepsinogen or papain treatment. We simply do endoscopy and remove the foreign body, food bolus. So short scaling can cause aphasia, sudden aphasia, rarely called steak house syndrome. This is MCQ, okay? And this only causes liquid dysphagia, only causes solid, no liquid. That's another important point, and this is symmetrical. At the lower esophagus G junction. All these points you have to remember, part of MCQs. Now this, I would say, is a very important X-ray. For Plummer-Vinson and short scaling, I said, no, those are not important. This is one of the X-ray which for radiology for you comes in triage red zone. I'll say red, yellow, green, black for triage for you. This I'll keep in green zone. Not black, because nothing is black in MCQ. They can ask anything, that's the problem. But, anything. But this is unlikely to be asked. And this comes under red zone. Very important, bird beak. It may become long and called rat tail sign. Rat tail sign more often we get in cancer, but achalasia also can give rat tail sign. So this is a bird beak sign of achalasia. Now the salient points we need to know about achalasia. This is due to absence of inhibitory fibers of Auerbach plexus. In GIT we have two layers of ganglion. One submucosal, one muscle. What we call submucosal, what's the name of submucosal ganglion? No, Meyntrich is a submucosal. Myo means muscle. Myopathy, myalgia, myo means muscle. So what is Meyntrich? Muscular. Name itself is self-explanatory. Myo means muscle. Auerbach and Meyntrich are same. It's called Meissner's plexus, Meissner. Okay, Meissner's. And in normal individual, not achalasia, normal, I'm talking normal, me, you, anyone. In love and belly, it says Meissner's plexus are sparse, less in esophagus. While many books say they are absent. So Meissner's does the job of absorption. And we know absorption doesn't take place in esophagus. We don't need Meissner's in esophagus. So in any case, Meissner's esophagus has nothing to do. And Meissner's are not involved here either. Second is in the muscle. Where in the muscle? Between circular and long-chain muscle. They are called Auerbach or Meyntrich plexus. And they are motor. They control the motility. So in Hirschsprung, same thing happens. Ganglions are absent. But total absence of ganglion. Meissner's gone, Meyntrich gone, Auerbach or Meyntrich are same. While here, I'm repeating, only Auerbach inhibitory ganglions are absent. So ganglions are present. Understood? Meissner's in any case has nothing to do with the esophagus. Only Auerbach we are concerned with. In Auerbach, only inhibitory fibers are absent. That's why biopsy we don't take. Ganglions are there. How biopsy will help? While in Hirschsprung, biopsy is gold standard. Here, biopsy has no role. There are ganglion. So biopsy will show ganglion. The inhibitory ganglions are absent. Understood? And which ganglion? Auerbach. This is a very important. You have not done your DQB, it means. In DAMS DQB, we have a question on this. Meissner's and Meyntrich, which is absent. Okay? So, this is inhibitory Auerbach. Number two, this is called secondary, primary achalasia. What's secondary? Caused by infection, Chagas disease. And what is pseudoachalasia? This also is MCQ. This is due to cancer. Some cancers of surrounding areas, not esophageal cancer, lung cancer, cardiac. Remember, cardiac cancer is the most common cause of pseudoachalasia, very old question. Pseudoachalasia due to cancer. They interfere with the motility called pseudoachalasia. Which cancer? Cardiac, lung, pancreas, any surrounding cancer. Cardiac is most important. And remember, achalasia is a condition of 20 to 40 years. Maybe 15 to, we can make spectrum little, wider. 15 to 50 years. But not in children, not in old age. Second and third, 20s and 30s. And another important point, dysphagia starts with liquid. Unlike all other conditions, stricture, cancer, dysphagia starts with solid. Here, I think in DQB, in your worksheet, most of the lines are written there. So it starts with liquid, okay? And now this is again a tricky point. Watch at the screen. The achalasia problem is here, where the ganglions are absent in the lower part. And if we get cancer of the lower part, it will be adenocarcinoma. But in achalasia, we don't get cancer in the diseased area, which is lacking ganglion. We get cancer in the normal area, which is the normal ganglion, the dilated esophagus. And which cancer we get? Squamous cell cancer. Remember this. Squamous cell we get in upper 2/3, adeno in lower 1/3. So in achalasia, the defective segment is lower. The absence ganglion segment is lower. But the cancer we get is in the upper dilated part, which is a normal ganglion. So it is squamous cell cancer. So this you have to know. This squamous cell cancer. And in X-ray, mainly we get bird beak sign, but sometimes we can get rat. If I ask where you get rat tail sign, the answer should be cancer. If you have to mark one. Cancer is, but it's not considered only for cancer. Even in achalasia, you can get rat tail sign. And manometry, not here in any motility disorder. Manometry is the investigation of choice. Any motility disorder. Nutcracker esophagus, DES, gold standard. This is the gold standard, manometry. We have a Chicago classification manometry. And Hiller's myotomy and partial fundoplication is not for achalasia. After myotomy, patient develops reflux. And to prevent reflux, we normally combine myotomy with fundoplication. So fundoplication is combined with myotomy, not to treat achalasia, but to prevent reflux. So, and there's a new treatment called POEM, per oral endoscopic myotomy, which I'll show you. This, which I'll show you in the surgery part. There's a slide on surgery. And this also is a very, very important X-ray for you. Just X-ray, this topic they don't ask, but this X-ray they do ask. What is this? Corkscrew appearance in diffuse esophageal spasm. This also I'll keep in the red zone of triage for you. Corkscrew appearance image in DES, diffuse esophageal spasm. Now, the hiatus hernia, sliding and rolling. In sliding, the GE junction goes up and it slides above the diaphragm, while in rolling, a fundus part goes up, GE junction and cardia is below the diaphragm. So this is sliding where you can see sphincter is above, and this is rolling where the sphincter is below, a pouch of the fundus has gone up. What are the salient features we need to know? Sliding is more common, more than 90%, rolling is 5%. Mixed is hardly 1-2%. And when you have other part of bowel like jejunum, that's very rare. That's not even 0.5%. Sliding presents with GERD and managed conservatively. Very rarely we do surgery for sliding, managed conservatively. While rolling presents with complications are very high. In rolling hiatus hernia, patient can develop ulcer here. Can you tell me the name of ulcer? Cameron ulcer. In stomach, ischemic ulcer have name. In head injury, we call them Cushing ulcer. In burn, we call them curling ulcer. You know the difference? Curling ulcer is not due to more acid production. Curling ulcer is due to ischemia, and Cushing ulcer are due to more acid production. Okay? So that's why Cushing ulcer more in duodenum and stomach, while curling ulcer in the fundus of the stomach. Site are different. So all ischemic ulcer in the stomach have name. So here also we call them Cameron ulcer, C-A-M-E-R-O-N. I'm finding it difficult to write with this pen on this surface, very smooth surface and vertical. C-A-M-E-R-O-N, Cameron ulcer. Cameron ulcer is the ulcer of fundus and rolling hiatus hernia. And rolling hiatus hernia, the complications are much higher, so always we do surgery. What surgery? Same what we do for reflux, fundoplication and pleuroplasty, Allison repair. I'll show you the image of fundoplication later on. So fundoplication and Allison repair. Okay? This is what we do. This X-ray I will keep in red zone. This is important. Sliding where the pouch has gone up, rolling, the G junction gone up, rolling where the stomach pouch has gone up. So this X-ray definitely can become a MCQ. These are the important X-ray. Bird beak sign, sliding hiatus hernia, corkscrew appearance, and Zenker diaphragm. While other X-rays I've shown, I will say less important. I wouldn't say that they won't be asked, but less important definitely. Dekho, in hiatus hernia, if I take normal abdominal X-ray, I find a air shadow here. This is called fundal gas shadow, and this is in the stomach of the fundus, which is normal. While here the stomach has gone up, the fundal gas shadow should have been here, and I see here. So what we find? Retrocardiac air fluid level. This X-ray will not come in your exam, don't worry. 99% they don't give you an image-based question. But theoretically, it's already a question asked 2 years back that there is a retrocardiac air fluid level. What is the diagnosis? Are you following what I'm saying? The stomach normally is like this, so air fluid level should be here, fundal gas shadow. While in this case, the stomach is like this, so where the air shadow is here, much higher, above the diaphragm. So this is a retrocardiac air fluid level, okay? So this X-ray is unlikely to be asked, but theoretically it is a question already. Understood this? Now, this X-ray again, this will never become a question image-based, very unlikely. Theoretically, remember, can you tell me where you get double barrel sign? Yeah, good, very good. Esophageal dissection, good. You see, this is the esophagus and someone is doing endoscopy and he perforates the esophagus. We call it perforation. But no, he only splits the wall. Wall is split. It's not gone out, not through and through. So like aortic dissection, for this the term is esophageal dissection. And which sign we get in esophageal dissection? We get double barrel sign. As I said, this is very unlikely that this will become an image-based question, but theoretically you remember double barrel sign is a sign of esophageal dissection. Another point you need to remember, it is managed conservatively. So we only manage, we don't do surgery. For dissection of esophagus, no surgery needed, only conservative treatment. But perforation, yes, surgery may or may not be done. That also is not an absolute indication of surgery. Sometimes we manage conservatively, but yes, very often we need surgery. So this is double barrel esophagus. Feline esophagus, as you already know, question has already been asked. Multiple transverse line in esophagus. And where you get this? This we get in GRD and eosinophilic esophagitis. This is a foreign body in esophagus. This was asked in last year NEET question. In esophagus, the foreign body will appear like coin will appear AP view like this. If it's in trachea, then foreign body or coin will appear sideways in AP view. So in trachea, sideways and esophagus. How to differentiate button batteries from coin? Both are round, small. Yes, you get a double ring sign. See here, 2 rings, while in coin, no ring. So double ring sign is a sign of, okay, so now it's stuck. Yeah, good. So button batteries gives a double ring sign. See, compare first and second image. So double. Now, this is a very, very important topic for you. You can understand the importance of this topic, congenital hypertrophic parstenosis, or also called infantile hypertrophic, by the fact that last year in June it was asked, this topic was asked in foreign medical graduate exam. Last year in July it was asked in INICET. Last year in September it was asked in NEET. So in 2021 all 3 papers had a question from this. It's a very, very important topic. You have to know this very thoroughly. And all the lines I've written here are part of MCQ, you know. So congenital hypertrophic parstenosis or infantile hypertrophic parstenosis, more common in male, 4:1 ratio. This will present with there is no problem antenatal, no problem, no obstruction, nothing. Child is fine, even after birth he is fine. The problem, normally he develops between 2 and 8 weeks, more often 4 to 6 weeks, 3 to 6 weeks rather. And you will find a olive-shaped lump and left to right peristalsis. Now, this is my assumption. Now you are getting questions on video also. If at all, if ever, they ask video sign symptom question of abdomen, I can tell you this will be one of the very first video you will get in exam. This condition is quite common in India. It's not common in Hispanic and Mongoloid people. It's common in white and Asian, brown, India and white, and relatively rare in blacks, but not in Mongoloid, not in Hispanic. So it's very common in India, a very important topic, that's why they do ask. So remember, you can have a question where you have a lump in epigastrium and a left to right peristalsis. This is a very classical feature of CHPS. A young child having non-bilious vomiting, like 4 or 5 weeks old child, non-bilious vomiting, projectile. And this word is also important. In adults, if you have gastric outlet obstruction, the vomiting is regurgitant. Cancer is the main cause and ulcer is second most common cause. And stomach is full of water and food. you shake the patient, you can hear the sound of water called succussion splash. While in this condition, stomach is empty, no food. He takes milk, he vomits milk, stomach is empty. What kind of vomiting? Projectile. So unlike adult which has a regurgitation vomiting, here you have projectile vomiting. And olive-shaped lump, left to right peristalsis. Protein energy malnutrition absent, polyhydramnios absent. Why polyhydramnios absent? In GIT obstruction antenatal, we should get polyhydramnios because I told you antenatal there's no problem. Problem only is postnatal. Only after birth, after 3-4 weeks. So that's why no polyhydramnios. Ultrasound is investigation of choice. This is empty stomach. This is like a cervix. So that's why we call it cervix sign. And these two figures you need to remember, this is optional. Length more than 16 millimeter and thickness more than 4 millimeter is diagnostic. Width, like here, this is the length, and this is the thickness, and this is the width. So width is optional, width is not important, but length and thickness, an empty stomach. And what sign you get on ultrasound? 3. Target sign, as you see here, this is called enteral nipple sign and cervix sign, looking like cervix. What about barium sign? String sign, this last Sunday, INICT 2 Sunday back, string sign was there, CHPS. We batched the following question, string sign for CHPS. This is the string sign, this one. This is a hypertrophied pylorus, and this is the string here. Stretched pyloric canal giving string sign. And this is a duodenal bulb giving mushroom sign. So this is the string sign and mushroom sign. Double track sign, caterpillar sign, shoulder sign. These are signs of barium yield. And in X-ray, you may find single bubble sign. I don't have X-ray here, single bubble sign in X-ray, okay? So these signs you need to remember. Now, what electrolyte abnormality? Hypochloremic, hypokalemic, alkalosis, and aciduria. I have a question for you. Why aciduria? Say it again. The reason is aldosterone. The sodium is lost, water is lost, hyponatremia and dehydration stimulates aldosterone from zona glomerulosa of adrenal. And what is the job of aldosterone? I'm sure you know. Absorption of sodium and water, excretion of potassium, hydrogen, and magnesium. So in urine, sodium, that's why I did not write hyponatremia here. Although sodium is lost, but I did not write why? Because sodium has been corrected by aldosterone. So within few hours, say 6 hours, 12 hours, when there's a hyponatremia and dehydration, this gets corrected. Sodium gets corrected, and rather than sodium, the child starts excreting hydrogen through the urine, and he develops acid. It's exactly opposite to what normally should happen. Urine alkaline, blood alkaline, urine should be alkaline. But blood is alkaline, urine acidic, that's why the word paradoxical. And this is due to aldosterone. So remember this word, this line actually you have to remember. Very, very, very important line. Very frequently. Last year also this was a question. So hyponatremia you may get for initial few hours. Once hyponatremia is severe, aldosterone stimulated, sodium gets corrected and patient develops aciduria, okay? And never operate the patient unless you have correct the electrolyte imbalance. Fluid of choice is N/2 saline with potassium and dextrose. Potassium only added when urine output starts. This was the INICT last year, one line, true, false. So potassium only added when child starts passing urine. Till the time it's not passing urine, don't give. And I have a question for you. Why Ringer lactate is not fluid of choice? Why N/2 saline? Say it again. Very good. Already alkaline. देखो क्या होता है? What happens? Ringer lactate is a very good fluid for trauma, burn, shock, etc. Why? It has osmolality of 277. Blood osmolality is 280, 290. It's isosmolar. Number 2, it has sodium 130, potassium 4, chloride 10, and 110. And so it has all electrolyte. Plus the lactate goes to liver and through Cori cycle gets converted to bicarbonate. So what it does, it counters the acidosis. That's why in trauma, burn, and shock, we prefer Ringer lactate because child is, or the patient is in metabolic acidosis. Here the child is already in alkalosis. And the lactate is not lactic acid. No, it becomes alkaline in blood, in liver. So child is already alkalosis, so that's why lactate will increase that. The boy correctly answered, it increases the alkalosis. So that's why it's not contraindicated but not preferred. But in trauma, where there's acidosis, it's the fluid of choice. Okay? So we can give ringer lactate if N/2 saline is not available. Otherwise, this is the fluid of choice. And when this figure you need to remember, the best parameter to assess dehydration and hydration is urine output. And what ideal urine output you have to maintain? Why you have to remember this? The same figure we say in burn also. What is the ideal urine output for a child? 1 ml per kg per hour. So 1 ml per kg per hour, once you have achieved this urine output, means you have corrected dehydration. Once you have achieved bicarbonate less than 30, means you have corrected alkalosis, and now you can operate. What surgery you do? Ramstead pyloromyotomy. And again, one word of caution. Don't confuse pyloromyotomy with pyloroplasty. They are different surgery. In pyloromyotomy, as you can see, only the pylorus muscle is cut, not the mucosa. We do not open the mucosa. You know, it's a very simple surgery. It doesn't take more than 20 minutes. Cut the muscle, that's it. Don't open the mucosa. Because you have not opened the mucosa, you can give milk within 6 hours, and within 24 hours, chutti, discharge the patient. But suppose accidentally I open the mucosa, then I have to keep the patient in lowly for 48 hours. So that is called pyloroplasty. That's a different surgery where I cut the mucosa and repair. That's for drainage. That's for adult drainage. But here we don't say pyloroplasty, don't open the mucosa. It's called pyloromyotomy. Very important surgery for you. Some names you need to remember, some you need not. Ramstead you have to remember. This surgery was done by 2 surgeons, Ramstead and Fredet, in 1920, almost 100 years ago. Still we are doing the same surgery. Fredet name is not important, only remember Ramstead pyloromyotomy. Now, this X-ray, I am sure 100% student should identify, and you can identify. If you cannot identify this X-ray, then that's not a good sign. And this is what you see here, air below right. We can see air below left diaphragm, but below left diaphragm, it's already, there is fundal gas shadow creating confusion, so we don't see left side, we only see. CHPS is congenital hypertrophic pyloric stenosis. Congenital hypertrophic or CHPS, okay? Right, so this is a very favorite question for, MCQs. Hollow viscous perforation, air below diaphragm. 2 more X-rays. See, volume, air less, air more, doesn't matter. All the diagnosis is same, air below diaphragm. Another sign of pneumoperitoneum is regular sign. This I'll keep in red, double red zone for triage for you, and this I'll keep in yellow zone, not green zone. I mean, it's important, less important. This can also become an X-ray. Regular sign and regular triad, 2 terms you need to know in abdomen. Where you get regular triad? Yeah, that was the last year NEET question. Gallstone Ileus, I'll show you that next slide. Regular sign is a sign of pneumoperitoneum where I can see the bowel wall. You see, this is a bowel wall. Yeah, this one. And why I can see the wall? I mean, all the yellow arrows are showing bowel wall. Why? Air here, air here. So when air is on both the side of wall, in the lumen and outside, the air has leaked outside, then I can see the white wall in between. That's called regular sign. While regular triad is a triad of gallstone ileus. This already is a question of 2021 NEET. Regular sign, pneumoperitoneum, regular triad, gallstone. What happens in gallstone ileus? The stone goes in ileum and gets stuck. Distal, any ileal obstruction. So you find a stone in bowel, you find obstruction, dilated loop, and you find air in the biliary tree. This is called pneumobilia. So air in biliary tree, stone in ileum, and obstruction is called regular triad. That suggests gallstone ileus. Now, double bubble sign. Where you get this? Yes. If there is an obstruction in the second part of duodenum caused by duodenal atresia, most important, or annular pancreas, less important, or Latz band, least important. Anything causing congenital obstruction. This is not specific for duodenal atresia, any congenital obstruction of second part duodenum. Latz band is least important, and this you get in malrotation of gut. Probably we have a question on, later on a image on that. So, no air should be found in abdomen. No air, except 2 air. This is the supine view and this is the erect view. In erect you will find air fluid level, and in supine you find round shadows. This is stomach, this is duodenum. This is stomach, this is duodenum. Both are same. One erect, one supine. So don't get confused if you get supine view or erect view. In supine, you get round shadow. In erect, you get AF fluid level. Both are developable. This, of course, is a triage red X-ray for you. Important X-ray. What happens where the obstruction is? The obstruction is always ampulla of Vater here. Here, second part, this is the stomach. Second part, duodenum distal to ampulla of Vater. So obstruction is distal to ampulla of Vater, second part duodenum. That's why vomiting is bilious. Why? Obstruction is distal. So you have bilious vomiting. And Down syndrome, and the most common GI anomaly in Down syndrome is duodenal atresia, 30% association. And all GIT obstruction antenatal can cause polyhydramnios. So here also you may get polyhydramnios. Why not in CHPS? I told you in CHPS, antenatal, there's no problem. Problem starts only 3-4 weeks after birth. So you will get polyhydramnios here. And X-ray will get Dolbear sign, and treatment is duodenostomy. Simple anastomosis duodenum with the duodenum, proximal duodenum, distal duodenum. This name is not important. So I said Hiller's myopathy is a very important name for MBBS. Ramstead is very important name. Kimura is not important. It's optional. If you remember, good. If you don't remember, fine. Because I'm quite confident this question will never be asked. If even in Viva, someone asks what's the treatment for duodenal atresia, don't say Kimura operation. Say duodenostomy. Diamond shape duodenostomy. So this line is important. This line, not this word. It's good that you know, but it's unlikely to become MCQ. This is corkscrew appearance. Corkscrew appearance I showed earlier in barium swallow and DS. This is a corkscrew appearance that you get in midgut volvulus. Later on I'll show you one more. So what is the normal rotation of bowel? The bowel when comes in the abdomen, the cecum is here, then here, then here. This is called 270-degree anti-clockwise rotation. So normal rotation is 270-degree anti-clockwise. This can get stuck at different places, like if the cecum gets stuck here, 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 left side. Then this is called non-rotation, gets stuck here, incomplete rotation, comes here, remains mobile, that's called non-fixation. So non-rotation, incomplete rotation, this is one is non-rotation cecum, here cecum is incomplete, and here it will be non-fixation. All will have little different presentation. In non-rotation, like cecum in left side, that will cause Latz band obstruction of duodenum. So if the cecum is here, then that's called non-rotation. That causes Latz band obstruction of duodenum. If the cecum comes subhepatic, that causes midgut volvulus, and the cecum is mobile, that will cause volvulus, cecal volvulus. So I'll just draw it here once more, what I said. If the cecum stops here, that is non-rotation causing Latz band obstruction. If the cecum stops here, that's called incomplete rotation, that will cause midgut volvulus. And if the cecum stops here, not stops, it's completion, rotation is complete, non-fixation, that will cause cecal volvulus, right? This is what is written here. And this is another sign of midgut volvulus that you get in CT scan called whirlpool sign. So midgut volvulus has two signs. One is corkscrew appearance in barium meal follow-through. Barium meal follow-through is the investigation of choice for malrotation. So for malrotation, barium meal follow-through is investigation of choice. CT normally we avoid in children, like due to radiation exposure. So barium meal follow-through gives corkscrew sign for midgut volvulus, and CT scan gives whirlpool sign for midgut volvulus. Now this is what I was talking about. If the cecum stops on the left side, complete small intestine on the right side and large intestine left side, this is non-rotation. A band goes here in front of duodenum causing obstruction called Latz band. If the cecum stops here, that's incomplete, then we have volvulus. Or it can be reverse rotation while the colon goes behind the duodenum, which is very rare. This X-ray again comes under double red triad zone for you. And this is a X-ray of obstruction. How to differentiate small intestine from large intestine? The large intestine is peripheral and small is central, plus large intestine will have haustra. You can see haustra here. So this is large intestine, this is small. So this is small intestine. Central, peripheral, plus no hostra. These lines are not hostra. These lines suggest they are jejunum called volvuli conventis, which is my next question. And this X-ray is multiple air fluid level. Very, very, very important X-ray for you. Gas pillar diaphragm, air fluid level are very important, both of them. So whenever you find multiple air fluid level, erect view. This is the obstruction. And this is how you differentiate jejunum from ileum. See this part, see this part. These has lines like here, they have line and this area no line. So this is called volvuli conventis, this is jejunum, while this is ileum. And this is how you know the site of obstruction. Earlier, like before 2021, I used to say only air fluid level is important for MBBS exam. But last year in NEET, they did ask the site of obstruction, so even that has become important. How many air fluid level are relevant? In children, more than 5, in adult, more than 3. So in children, more than 5, and in adult, more than 3 are considered significant, and they suggest obstruction. While site we know by supine view, like here I can see the air going up to this, or here I can see air going up to this. So in both the cases, this is an ileal obstruction. So to differentiate jejunum and ileum important for you. Now they are asking question like this. So this is jejunum, this is ileum. This is again which part of the intestine? Jejunum. Why jejunum? Because you can see lines across throughout the one wall from other to the other wall. This is called volvuli conventis. This is jejunum. This is another minor topic of colon called Ogilvie syndrome or colonic pseudo-obstruction. You can see hugely dilated colon, and this is a non-mechanical obstruction. This is the most important point. No stricture, no cancer, no volvulus, no anatomical narrowing, non-mechanical. What happens in Ogilvie syndrome? In Ogilvie syndrome, parasympathetic suppression, sympathetic stimulation. Parasympathetic suppression and sympathetic stimulation. And X-ray will show hugely dilated colon and air up to rectum. This point is important. You see air. Another important point in Ogilvie or colonic pseudo-obstruction, gangrene starts where? Gangrene, if in colon it becomes gangrenous, which part? Cecum. Cecum is hugely dilated. All back pressure comes on cecum. So cecum becomes dilated and gangrene starts from cecum. Treatment is conservative, drug of choice is neostickmin. These are the lines you need to remember. You can add one more line if you feel like that may become a line of MCQ. The transition zone for Ogilvie syndrome is at sigmoid, is at splenic flexion. So transition zone in Ogilvie syndrome is at splenic flexion. That is one more line you can add if you want. Not very important, but may become a line. So parasympathetic suppression, sympathetic stimulation, non-mechanical obstruction with massive dilatation of colon. These are the points you need to remember about Ogilvie syndrome. These are MCQs. This is a rare X-ray of pediatric condition, but again, this I'll keep in yellow zone, not in red zone. Unlikely to be asked, but may become a question. Whenever you find a colon-like thread in a neonate, a child is born, he has not passed meconium. You do contrast study and you find image like this. What is the diagnosis? Microcolon has 3 etiology, only one you need to remember, and that is meconium ileus. Whenever you get a picture like this, your answer is meconium ileus. Unlikely to become an image-based question, but yes, it can become an image-based question. Unlikely, but it can be asked. There are 2 more causes. One is bowel atresia in fetus, atresia, jejunal or ileal atresia. Second is total colonic aganglionosis. Hirschsprung, but involving a whole colon, which is very, very, very rare, called Zulzer-Wilson syndrome. Not an important name. This name you can skip, not important. So if ever you get a question like this, image-based, what is diagnosis? Don't worry, very confidently, just mark one, meconium ileus. That is, in which condition you get meconium ileus? Cystic fibrosis. And what is the first treatment here? First step. Say it again. Gastrografin enema. So when you have meconium ileus, you have 2 treatments. First, 2 attempts of gastrographic enema. Second, Bishop-Koop operation. Don't do operation first. Give gastrography and enema. It doesn't work, then go for Bishop-Koop operation. So, meconium ileus, when you have an X-ray like this, always say meconium ileus, right? Rapunzel syndrome, this I don't think I need to show you or need to tell you. This is trichobezoar. Young female, less than 25 years, psychiatric patient. In exam, you will have question like patchy alopecia. Why alopecia? She plucks hair and eat hairs. And most common presentation, obstruction. So she comes with vomiting. So obstruction, mobile abdominal lump, which shows indentation, patchy alopecia, young female. This is Rapunzel syndrome. Rapunzel syndrome is trichobezoar. You see? This can be diagnosed by CT, X-ray, CT, barium or ultrasound, but CT is best. Now, thumb printing is a sign of ischemic colitis. And in ischemic colitis, you have to remember 2 points. What is the most common site for colonic ischemia? The most common site is splenic flexure called Griffith point, followed by rectosigmoid junction called Sudak point. These are the 2 most common sites of ischemic colitis. Griffith point and Sudak point. Where's the Griffith point? This is most common. And splenic flexure. And this is a watershed area. And this is Sudak point. This is the second most common cause of site of ischemic colitis. One more tricky question. This was asked in AIIMS few years back. If I say, what is the most common site of ischemic colitis? You will say splenic flexure. But if I twist the question, if I say, what is the most common site for ischemic stricture, not colitis, stricture, then the answer is sigmoid corona. Sigmoid has the narrowest lumen. So most common site of ischemic colitis is Griffith point, splenic flexure, and most common site of ischemic stricture is sigmoid. Okay? Rectosigmoid junction. Sigmoid, because that is the narrowest. Now, accordion sign, seen in pseudomembranous colitis. Target sign, acute mesenteric ischemia, mainly venous thrombus. You get this when there's a bowel wall edema. So in arterial thrombus or embolus, you'll not get only venous thrombus, edema. So target sign, you get an edema. That is basically acute venous thrombus. And Combs sign, as you know, is Crohn's disease. This is due to mesenteric edema and mesenteric fat creeping and hypervascularity, Combs sign. Sandwich-Einberger sign is mesenteric lymphoma. Now, few points about diaphragmatic hernia. You see, diaphragmatic hernia, it's from the foot end. So this is left, this is right. Diaphragmatic hernia, 2 type, Morgagni and Wojciech and Morgagni. It is due to persistence of pleuroperitoneal canal. Pleuroperitoneal canal fails to disappear. So due to persistence of pleuroperitoneal canal, it is found. And most common is Bogdalek. Where the Bogdalek is left side posterior. And where the Morgagni left side posterior. Where's the Morgagni? Right side interior. Bogdalek presents acute emergency in children. Morgagni can present late also. The Bogdalek left side posterior, Morgagni right side. And this triad is the triad of diaphragmatic hernia. What triad? First abdomen scaphoid. There's no bowel here. All the bowel is gone. And this X-ray also I'll keep in red zone for triad. You can see no air in the abdomen. Rather, all the air is in the thorax because intestine has come here. Though I can call it gastrous abdomen, but if ever a question comes and where you get gastrous abdomen, the best answer is type 1 TEF, tracheostomal fistula type 1, type A. So, scaphoid abdomen because there's no bowel here, respiratory distress, and some book do say dextrocardia, but this is not true dextrocardia. The heart is pushed to the right side, that's why you get heart on the right side. It's not anatomically located there. And the cause of death, this also is a question, is pulmonary hypertension, along with pulmonary hypoplasia, lung maldevelopment. And treatment always is through the abdomen, never ever repaired through thoracotomy. It is always repaired through laparotomy or laparoscopy from the abdomen, not from the thorax. So you can reduce the bowel from abdomen and close from the abdomen side. Hernia defect closure from abdominal side, okay? Apple core, this is a barium enema. Again, a very, very important sign for you. This will become MCQ in exam. Apple core, which side? You see, mainly in colon. I can see Hostra, so we can see it's colon. So apple core, you can get an end tubular structure like esophagus also. But there it's rare. It's more common in colon. These 2 are also apple core. I have kept 2, 3 because this is an important X-ray. Now, apple core and apple peel are different. Apple peel also is an old MCQ. Apple peel we get in bowel atresia type 3B, while apple core we get in colon cancer. So apple peel in bowel atresia type 3P. Okay? Clause sign, this was a question of this very year in NEET 22, May. And what are the features under subsumption? Normally seen from 6 months to 1 year due to weaning and enlargement of Peyer's patches. Peyer's patches hypertrophy are the most common lead point. Adenovirus type 3 is another very common cause of intussusception. Which vaccine can cause intussusception? Can you tell me? Last year NICT question? Very good. Rotavirus vaccine. Absolutely fine. It's good that you know. This was a question last year, rotavirus. Ultrasound shows target sign and pseudokidney sign. It will not become MCQ. CT scan also show target sign and bowel inside bowel. This is what you get. Coil displaying sign, you also get an intussusception and bowel hematoma. But clause sign is a very, very important. I'll show you many clause sign because this is important. Types, ileocolic is most common, ileum goes in colon, but in adults, colocolic is most common. So ileum goes in colon, that's the most common, while in adult, colon going to colon is most common. And the treatment, of course, clinical feature, red currant jelly stool, empty right iliac fossa called sign of dance, and banana and or sausage shaped lump. So if you examine, you find the right iliac fossa is empty, you find the lump in epigastrum, which is a banana or sausage shaped lump, and you find red currant jelly stool. These are the features of air reduction or enema reduction can be tried, otherwise go for surgical repair. This is one clause sign, this is another clause sign, and these two are also clause sign. I am showing you 3-4 clause sign because all of them are intussusception, and this is one of the important X-ray for you. Meikles. Meikles actually is the most common congenital anomaly with the incidence of 2%. So most common congenital anomaly is Meikles due to persistence of, remember the word proximal also. It was a part of Ames question. Proximal end of vitellointestinal duct. So proximal end of vitellointestinal duct or vitelline duct present at antemesenteric border, and there's a rule of 2. What is rule of 2? 2% incidence, 2 inches long, 2 feet proximal to ileocecal junction. So 2% incidence, 2 inches long, 2 feet proximal to ileocecal junction. And always it has its own separate blood supply. It never takes branch from the ileal artery. It has a separate vitelline artery which supplies. So it has a separate blood supply. And it very often, 50% it has ectopic gastric tissue. This is a INICT 2022 May question. Which ectopic tissue you get? Gastric and pancreatic. Most common gastric followed by pancreatic. So ectopic tissue is there. And when we have gastric tissue, then we can go for technetium scan. This is stomach, this is urine, this is Meikles. So technetium scan is very, very good. Only when ectopic tissue is there, otherwise contrast study. So bleeding is the most common presentation, mainly seen in children. Only when ectopic tissue is there, and obstruction in adult. These are the two main presentation. Bleeding in children, obstruction in adult. Bleeding 50%, obstruction 30%. This you get in 50% and this you get in 30%. The technetium scan is only for ectopic mucosa, so when ectopic tissue is there, you can see. Otherwise, we go for contrast study. See, this is a contrast study showing Meikles. So ectopic tissue there, you can go for technetium scan, otherwise contrast study. And the treatment is diverticulectomy if no ectopic tissue, otherwise resection and anesthesia if ectopic tissue is there. So how you treat Meikles? Diverticulectomy, and best way to do diverticulectomy is wedge resection. You can write one more word in front of diverticulectomy, by wedge resection. So diverticulectomy is the best treatment by wedge resection or resection and anesthesia if ectopic tissue is not there. This again, I'm sure all of you can identify, coffee bean sign, sigmoid volvulus, which you get in old person. This was a question of INICT this year only. Coffee bean sign. This one, all. This, and this. All three are sigmoid volvulus. And this is the bird beak sign which you get in barium in sigmoid volvulus. This one, here. This is a bird beak sign of cecal volvulus. Cecal volvulus also give bird beak sign. Like sigmoid, the site will differ. This is cecal volvulus. Sawtooth appearance, this also comes under red triad zone for you. Sawtooth will become MCQ in near future because clause sign they asked this year in NEET, Coffee bean signed this year in INICET. So now comes the sawtooth appendix. Again, important. So this may become MCQ in near future. Sawtooth you get in diverticulosis is seen in old age. In India, our diet has lots of fiber and roughage, so it's rare in India. Mainly involves sigmoid, presents with bleeding. Bleeding is from the right side and diverticulosis from the left side, diverticulitis. And main artery bleeding is superior mesenteric artery because bleeding is from the right side. This is MCQ. So main artery that bleeds in diverticulosis is from the superior mesenteric artery branches. Hinche classification has been asked once. So remember, Hinche classification is used for diverticulitis. I'll not discuss this in detail. Now, some names of surgeries, about 10, 15, 20 names, 1 dozen. Dolman operation, as I told you in the first slide in Zenker, Dolman is an endoscopic procedure. This was 2019 NEET question. This is an endoscopic stapling procedure for Zenker. You simply cut the diverticulum through the Zenker from inside. This is the cricopharynx you have cut. So Zenker ke liye Dolman you can do endoscopically. Fokker type A, T, E, F. This I wrote earlier. For pure atresia, you can do Fokker. Heller's myotomy, you know, is done for achalasia. And now it is preferred laparoscopically, only laparoscopy and laparotomy, not done by thoracotomy. It will lead to reflux, so DOR fundoplication can be added along with. Don't do complete fundoplication distance, only partial. Ramstead pulmonary for CHPS, as you know, you simply cut. You do have questions on surgery. Last year, they asked for one question. This year also, they asked one question. So now they're asking image-based question also, so I've kept this. Because trend is changing, you never know. So that's why I've kept this. This is a duodenoscopy. Make a vertical incision here, horizontal incision here, do a duodenal anastomosis called diamond-shaped duodenoscopy done for duodenal atresia, Kimura operation. This is the LATS operation for malrotation. Basically what happens, you have details probably is not needed. I doubt that they'll ask. This is the All India question. LATS operation is done for what? This is done for malrotation. Details are not needed, but I think it's written in your book. You cut the LATS band, bring the cecum here and do appendicectomy. 3 steps you do in LATS operation. Bring the cecum to right side, cut the LATS band and do appendicectomy. Bishop Coop, as I told you verbally, Bishop Coop basically is a surgery for meconium ileus. First you give gastrographin enema twice. If it works, relieves obstruction, good. If it does not relieve obstruction, go for Bishop Coop operation. In Bishop Coop, distal ileum is exteriorized and proximal to distal end-to side anastomosis done. Remember, in Bishop Coop, distal is taken out. If I make other way around, proximal I take out and distal I anastomosis, that's called centrally. That's a different operation. So Bishop Coop, only distal ileum can be taken out. And then you do acetylcysteine wash. This surgery is not important in India because we don't get Crohn's that often. But in surgery, it's a very important surgery. Some question, some paper you may get this question. Cono S anastomosis is only done for Crohn's disease stricture. Just the name of surgery, Cono S. Cono S. Now these are some names for pulmonary surgery. Again, I don't think we need to know the detail. Bascom, we make incision away from the incision and go side laterally and excise. While in Caridacus, you make the incision on the sinus and excise. Bascom, don't make the incision on the disease part. In Bascom, we make the incision by the side, not on the disease area. While in Caridacus, we make the incision on the disease. This image you keep in your mind. This is a plastic surgery concept called Limburg operation. This you can do anywhere, including pulmonary sinus. This image already they have asked earlier that this image, not this same image, but this kind of image, what surgery is done. This is called Limburg operation. This is basically a plastic surgery concept done here also. 2 surgeries for short bowel syndrome. One is Bianchi operation, second is step. Bianchi operation is for short bowel. What are short bowel features? The length should be less than 200 centimeter. This is the definition. The gastric ulcers and hypergastremia are found. This is a question. that you have hypergastremia and short bowel syndrome. There's increased risk of gallstone. Which type of stone you get in short bowel syndrome? Only cholesterol. You don't get pigment stone. Now I'll ask a question. In pigment, what is the cause of black pigment stone? And what is the cause of brown pigment stone? First, black. No, infection is not black. Infection is brown. Black is due to hemolysis. Black pigment stone due to hemolysis and brown pigment stone due to infection. And cholesterol stone due to supersaturation. So in short bowel syndrome, bile salt become less, cholesterol become unsaturated, they form stone. And which renal stone you get in short bowel syndrome and any malabsorption? Again, important question, oxalate. Why oxalate stone? More absorption from gut and more excretion through urine. So in any malabsorption, which stone we get in gallbladder? Cholesterol, due to decreased bile salt. Which stone we get in kidney? Oxalate, due to more absorption through the gut and more excretion. And drug of choice is teduglutide. This also you remember, it can become an MCQ. Teduglutide, okay? Drug of choice, teduglutide. This is called serial transverse enteroplasty. As you can see, we have increased the surface area by making incision like this. This is another surgery for short bowel syndrome. So Bianchi operation, which is already a question, Bianchi operation done for what? Short bowel syndrome. And STEP also is done for short bowel syndrome. Rectal prolapse surgery, I think I'll just tell you the name. Last year there was a photo of Thiersch operation in NEET. In Thiersch, you apply a circumferential suture and simply tighten it. This is not a good surgery, only done for partial prolapse. Long-term results are not good, so it should not be done for complete prolapse. It's a very simple operation, that's why it's preferred. Can be done under local anesthesia, bedside, without any anesthetist need or operation theater. You can do bedside, so it's still done only for partial prolapse. Make a purse-string suture. And Delorme is basically plicating suture in the rectal prolapse. This is done through perineum. And Eltemier, where we do resection through the perineum and anastomosis, that is also through perineum. So Eltemier, Delorme and Thiersch, these are rectal prolapse surgery done from perineum. While rectopexy done from abdomen, Ripstein and Wells, you put a mesh and fix the rectum with the sacral promontory. If I put the mesh in between rectum and sacrum, this is called Wells, and if I put anterior, then it's called Ripstein. But I'm fixing it with the mesh. And this is a new surgery. This is important. This surgery may become a question called Dehoor operation, where I put the mesh anterior. You see here I'm fixing with the sacrum. And in Dehoor, we fix anteriorly, anterior ventral rectopexy, done by laparoscopy only. So I put the mesh anterior to rectum, and this is the uterus, this is the rectum. So the mesh is placed anterior. These three are surgery done by abdominal route, Ripstein, Wells, and Dehoor, while first three surgery are done by perineal route. Rectal cancer, two surgeries, they do ask anterior resection and abdominal resection. Anterior resection, this is the rectum, this is the anal verge, this is the line at 5 centimeter. If the cancer is above 5 centimeter, we do anterior resection. Below, from the anal verge, we do APR. So anterior resection is done when the cancer is above 5 centimeter. This is a very important point in rectal cancer surgery. Please remember this. And either 5 centimeter from anal verge or 3 centimeter from the dentate line. And we simply do resection and anastomosis, and safe margin is 2 centimeter. While APR, like here, you cut this area and do the anastomosis. While in APR, it is done when the cancer is within 5 centimeter from anal verge or within 3 centimeter from dentate line. And here you excise the whole area and do a colostomy. No anastomosis. You are not leaving anything in the rectum. Rectum is sphincter, everything gone, everything removed. And then do a colostomy, permanent end colostomy. So anterior resection, no, this is APR. So this is APR, huh? This is APR. So anterior resection you do when there's a cancer above 5 centimeter, and APR, abdomino-perineal resection, when the cancer within 5 centimeter. Two maneuvers in surgery. I have to mobilize ascending colon, make incision here, reflect, called cattle barrage, to reach vena cava or right kidney. This question is important. So this is called right medial visceral rotation, where I mobilize the colon to reach vena cava, right kidney, called cattle barrage. And if I have to mobilize left colon to reach aorta or left kidney, this is called Metox maneuver. So mobilization of descending colon by making incision by cytocolon, reflecting, Left visceral rotation is called Petox maneuver, and right medial visceral rotation is called Kettle-Barash maneuver. Just remember Kettle maneuver. So Kettle maneuver is mobilization of ascending colon, right visceral rotation, and Metox is mobilization of descending colon, left visceral rotation. Metox and Kettle-Barash, both names are important, like here. See, this is the mobilization of ascending colon here, called Kettle-Barash to kidney and right kidney and vena cava. This is for trauma also. In trauma, this is the approach. For nephrectomy, this is the approach, anterior. And Metox is mobilization of left kidney, left medial visceral rotation for aorta and vena cava. These names you need to remember. In new treatment, we have one treatment called HIPEC, hyperthermic intraperitoneal chemotherapy. In the abdomen, temperature is taken up to 42 degrees centigrade. First you do surgery, R2 resection followed by chemotherapy directly in the abdomen at 42 degrees. So HIPEC, hyperthermic intraperitoneal chemotherapy, is what? Only for peritoneum, not for cancers of the bowel, peritoneum. Mesothelioma, pseudomyxoperitonei, or peritoneal secondaries. So it's only for peritoneum, where first you do surgery, excise as much as possible, then hyperthermic intraperitoneal chemotherapy, 42 degrees centigrade, put chemotherapy in the abdomen and leave it there for 2, 3, 4, 6 hours depending on the extent. This is called HIPEC. This is a new technique being done in India. This machine was bought by AIIMS in 2013. Since 2013, Delhi AIIMS doing this. Last year I went to Lucknow, someone told me that even in Lucknow, HIPEC is being done. So now in India, many cities, HIPEC is being done. That's why it becomes MCQ also. So if a question comes, HIPEC is done for what? It's only for peritoneum, mesothelioma, pseudomyxoperitonei, and peritoneal secondaries from GIT cancers. Appendix, stomach, colon, and uterus, and not for liver, not for pancreas, not for high-grade cancer. They don't respond. But for colon, this is very good. Another treatment is papillon therapy. Now, this is not yet being done in India, but this is done in UK, and this has come in Love and Bailey last edition. Anything in Love and Bailey can become a question. Papillon therapy is only for rectal cancer. Rectal cancer, I told you, treatment is APR and AR. They do respond to radiation, but only early stage. So this is, we put a probe in the rectum with a radioisotope. So this is a contact rate, not external beam. Source is not outside the body, it's in the rectum. So this is external beam, nahi hai. This is contact radiotherapy only for early cancers. Till submucosa, that is T1, less than 3 centimeter, within 12 centimeter from anal verge, and no lymph node, no metastasis. So this is a contact radiotherapy, a new regime called papillon therapy. This is not yet MCQ, but can become MCQ in near future. This already is MCQ. I think there are 5 MCQs in last 20 years on Nigro regime. Nigro regime is like, this is the anal canal, this is the levator ani, pubertalis, dentate line. Above dentate line, we will have adenocarcinoma. Below dentate line, squamous cell cancer. Adenocarcinoma is treated by APR, just like rectal cancer. Squamous cell cancer is treated by Nigro regime. It's only for squamous cell cancer of the anal canal, where it is chemo followed by radio or concurrent. No surgery. Surgery is not a part of Nigro regime. So only, never say chemo, never say radio chemo. Chemo, radio. First chemo, then radio, or concurrent, but chemo, then radio. So 5-FU is the main drug, can be combined with either mitomycin C or porphyromycin or cisplatin. Any. You can choose any, but 5-FU one. So combination chemotherapy followed by radio. This is, now I can tell you, my gut feeling is this is going to become an MCQ next 2 years. Why I am so confident? This drug was approved last year only, I think August or September by FDA. Normally when a drug is approved, it comes in journal, then textbook, and then in practice. This came in newspaper. Why? This is the only drug which has given 100% response. The problem are there, but this is a very, very effective drug. Monoclonal antibody, dostarlimab, approved last year, but this will become MCQ. So remember the name. It is approved for PD1 or PDL1 colon cancer. PD1, programmed cell death or programmed cell death ligand. This concept got Nobel Prize in 2018 to scientist Honzo, Japanese, Allison, American. So please read about programmed cell death. So only for PD1 and PDL1 colon cancer, only DMMR positive colon. DMMR means deficient. MMR is mismatch repair gene. It's only for deficient mismatch repair gene. Only for deficient mismatch repair gene, DMMR. So either this will become a question that dostarlimab is approved for which colon cancer, or this will become a question that this is not approved for which cancer. For cystic tumor, it's not approved. For colon, it's approved. For uterine cancer and some other solid. But cystic, it's not approved. The problem is only 3% cancers are DMMR positive. So that's why it's only good for 3. But in 3% giving 100% response. Second problem, the cost. It's very expensive at this moment. One shot costs around 8-9 lakh rupees, and we need about 7-8 shots. So in total, we need 50-60 lakh rupees will be the total cost of the treatment. So very expensive, but approved last year, and this will become MCQ in near future. Another treatment is lutetium-117 dotatate. This is for carcinoid, neuroendocrine tumor. The dotatate gets attached to the receptors for somatostatin, and lutetium having high beta emission will destroy the tumor. So lutetium has a high beta emission, it destroys, and dotatate will get attached. And it's only approved for GI cancer. It's not approved for genitourinary or respiratory tumors, only carcinoid from GIT. And by GIT, I don't mean bowel, I mean pancreas and liver also. So liver, pancreas, intestine, any GI cancer, it should be somatostatin receptor positive. So any carcinoid which is receptor positive in GIT, lutetium-117 dot, like here, you see, this is liver secondaries of carcinoid. Impossible to do studies, so many secondaries. The liver is studded with secondaries and secondaries and secondaries. And this is after treatment of lutetium-177. So this is a new treatment, lutetium having beta emission, dotatate gets attached to receptor, takes the lutetium to tumor, and tumor destroys. So this is a new treatment. Hematopoiesis point, I think I can quickly go through them. The one-liners. How a upper GI and lower GI bleed are divided? By ligament of Tietz. And where the ligament of Tietz is? It is at the duodenojejunal flexure. This is duodenum, this is jejunum, duodenum, jejunum. So this is ligament of Tietz coming from left crus of diaphragm. So upper and lower GI bleed are divided by ligament of Tietz. Second point, what is the most common cause of upper GI bleed? Most common cause is peptic ulcer. In peptic ulcer, duodenal ulcer. So most common cause of upper GI bleed is duodenal ulcer. Third point, in children, most common cause of upper GI bleed, portal hypertension. And the main cause is extrahepatic portal vein obstruction, EHPVO. So upper GI bleed and lower GI bleed are divided by ligament of Tietz. Most common cause of upper GI bleed is peptic ulcer, in which duodenal ulcer is more common than gastric ulcer. Can you tell me which artery bleeds in duodenal ulcer? Gastroduodenal. And gastric ulcer? Left gastric. So gastric ulcer, left gastric artery, and duodenal ulcer, gastroduodenal artery. Gastroduodenal is much more common than duodenal bleed is much more common. So in children, most common cause of upper GI bleed is portal hypertension. And what is the most common cause in children of portal hypertension? Extrahepatic portal vein obstruction called EHPVO. Most common cause of mortality due to upper GI bleed, portal hypertension. Most common cause is duodenal ulcer, but they don't cause death. The death cause is portal hypertension. Though it's only 20% upper GI bleed, not most common. But mortality most common, portal hypertension. Other rare causes, that's not important. What is the investigational choice for upper GI bleed? Endoscopy. And what is the permissible time? Like bleeding is continuing, then I don't have time, I'll do immediately. Bleeding has stopped, then 24 hours. It should be done within 24 hours. Don't delay beyond 24 hours. First drug to be given in any hematemesis unrelated to cause should be IV pantoprazole. There are reports suggesting IV pantoprazole reduces the mortality. So first drug is IV pantoprazole. Varicose bleed drug of choice, octreotide, prophylaxis, beta blocker. Terlipressin is the most effective drug for upper GI bleed. Most effective terlipressin. But terlipressin normally we don't prefer because it's not even approved by FDA. Some countries they use because it causes mesenteric ischemia. It's very potent vasoconstrictor. And most common cause of colonic bleed is diverticulosis. Second most common angiodysplasia. Lower GI bleed, most common cause, diverticulosis, angiodysplasia. And bleeding per annum in India, of course, hemorrhoid, piles. So these some liners you need to know. In detection, what investigations we have to know the site? The minimal bleed we can know by technetium RBC scan. Here, see the last line. And it can detect as little as more than 0.1 ml per minute bleeding, followed by angiography that can detect 0.5 ml per minute, followed by colonoscopy which can detect at 1 ml per minute. Last line is quite important, please write it down or remember. RBC scan can detect the minimum. It will not tell you the vessel, which vessel. Angiography will tell you which vessel. In angiography, it's therapeutic also. RBC scan is not. But minimal bleed you can know by technetium RBC scan. Okay? Now, these classification given in your book, only 4 you need to know in detail. Rest are not. There is a question in All India naming classification used for what? It's used for gallbladder, but you don't have to memorize. Only 4 you need to know. One is Dukes. Dukes is very important. You get question on Dukes. Second, Seward. Third, Hinche. Fourth, Park. So only Duke, Seward, Hinche, Park for Fischler. You have to know in detail. Rest you can. And someone in chart wrote which TNM you need to know. In TNM, I would say only 6, 7. Most important, breast. Breast obviously is very important. Second, oral cavity. In India, oral cavity is important, so you have to know oral cavity. So breast, TNM, oral cavity. In urology, all 3. Kidney, prostate, testis. Bladder and penis you can remove. No. Kidney, prostate, testis, 3. And then both is skin. Melanoma and squamous cell. In melanoma, Clark's and Dressler both. So these, and in GIT, only one, colorectal cancer. Only one. Stomach, esophagus, nobody will ask. Liver, gallbladder, nobody. So I'll repeat. Breast, oral cavity, kidney, testis, prostate, colorectal cancer, and skin. This is, squamous cell melanoma. This is what I would say is very important. And less important, once they have asked lung and thyroid also, once. So if possible, remember. Otherwise, you can leave that part. So only these 7, 8, I think you should know. Now, margin, what is the safe margin for GI cancers? In rectum, just is a question, what safe margin to take? This is all India question. I remember in many guides, the answer given was 1 centimeter. Probably later on they corrected, I'm not sure. So just rectum and carcinoid, 2 centimeter. Benign carcinoid, I mean. Just rectum and carcinoid, 2 centimeter. In gastric, 5 centimeter, esophagus 10, and colon also 5. Rather than 6, you can write 5, colon 5. So stomach and colon 5, esophagus 10, and rectum just carcinoid 2. How many minimum number of nodes should be removed in cancer? In stomach, either I can say more than 15 like this I write, or if I'm not writing more than, then I should write 16. So it should be 16 in stomach, 12 in colon, 6 in gallbladder, 10 lymph node minimum in breast. This is a last Sunday, 2 Sunday back INIC question, this year only, 2 weeks back. They made a table and asked which was correct, and breast had 10, colon had 12, but stomach I think had a different number, and gallbladder also had a different number. They were wrong, and stomach and colon were correct. So breast and colon were correct. So these are the minimum number of lymph nodes you have to remove in GI cancers, okay? If you have less than this number of lymph node, then that is an inadequate resection. Now, IBD differences, I think we can skip. This is not very important. This is discussed in medicine as well. So the difference between Crohn's and ulcerative, I just have to read, so you can very well read that. These points I think I'll read. You write it down. Dekho, which surgery will not affect the course of associated factors in ulcerative colitis? 2 conditions are not related to surgery. One is primary sclerosing cholangitis, second is ankylosing spondylitis. So surgery will not affect the course of these 2 pathologies associated. Primary sclerosing cholangitis and ankylosing spondylitis. Point number 2, erythema nodosum is most responsive to treatment. Among all, erythema nodosum is most responsive. Point number 3, Pyoderma gangrenosum is the most common skin manifestation of ulcerative colitis, more commonly seen than Crohn's. These are actually one-liners MCQs asked earlier. All these are old questions, but still, these are questions. First line is very important. Primary sclerosing colitis, no response to surgery. Fourth, EPASU, more common in Crohn's. What is EPASU? Erythema nodosum, peripheral arthritis, ankylosing spondylitis, stones, and Goetz ulcer. Which stone? I told you earlier. All malabsorption. In kidney, we have oxalate stone. And in gallbladder, we have cholesterol stones. Okay? So, EPASU is common in Crohn's, erythema nodosum, peripheral arthritis, ankylosing spondylitis, stones, and Goetz ulcer. Finally, ye important. Listen carefully. Just two lines. Any question, believe me, just two surgeries. If I say what is the best elective surgery for ulcerative colitis, elective, you will say total proctocolectomy and ileal pouch anal anastomosis. And which is the best emergency surgery like toxin-colon bleeding and ulcerative colitis? Total colectomy and Brooks ileostomy. In emergency, no proctum, no rectum, only colectomy. So best emergency surgery is total colectomy and Brooks. Whatever the question says, I can make a clinical question. A known case ulcerative colitis with X-ray and transverse colon diameter more than 6 centimeter. That's toxin-colon. With fever and diarrhea and TLC very high, what you'll do? Or hemorrhage uncontrolled, you go for total colectomy and Brooks ileostomy. And in case it is elective, then you do total proctocolectomy and ileal pouch anal anastomosis. Pouch can be JSW, whatever shape. J shape is most commonly used. Okay. So these lines are important in inflammatory bowel disease. Now, some general vascular compression syndrome. Wilkie syndrome is compression of duodenum. See here, duodenum. By this, the angle becomes less than 15 degrees. They cause obstruction. Common in young female, young thin female. Now, why I have written red color? I saw somewhere some people have said investment choice is CT angio. No, it's not CT angio. It is CECT. We don't want to see vessel. We want to see compression of duodenum by vessel, which we see better in CECT. So in Wilkie syndrome, investment choice is CECT, not CT angio. And treatment is gastrojejunostomy. This is the treatment of choice here. So Wilkie syndrome or CAS syndrome or superior, you see the fat gets depleted here. Like severe dieting, anorexia nervosa kind of young thin female, they do get this problem. Another condition is median arcuate ligament between, this is the right crus of diaphragm, this is the left crus of diaphragm, in between there is a median arcuate ligament, they compress the celiac trunk. This is called median arcuate ligament syndrome or Dunbar syndrome. So Dunbar syndrome or median arcuate ligament syndrome is basically compression of celiac trunk. This is just one liner question. In median arcuate ligament syndrome, what structure is compressed? Celiac trunk. Normally, as you can see in the third diagram, the median arcuate ligament is much higher than celiac trunk here. But now it is very close and compressive. This is called median. Third vascular compression syndrome, dysphagia lusoria. Which vessel is aberrant here? Right circular artery compressing the esophagus. And fourth compression, this is not a GIT compression, this is a vascular compression called May-Thurner syndrome, where the left common iliac vein is compressed by right common iliac artery here. So compression of left common iliac vein by right common iliac artery, this is called May-Thurner syndrome. So 4 vascular compression syndrome. Wilkie syndrome is superior mesenteric artery syndrome. Dunbar syndrome or median arcuate ligament syndrome. May-Thurner syndrome and dysphagia lusoria. Okay. Morbid obesity, this table becomes MCQ, like they do ask some question which is restrictive, which is malabsorptive. We don't have to know all the surgeries, we need to know only 4 surgeries. Rather 3, this, and this, and rarely this, only 4. This is most important, followed by this, only these 2 are important. So this table you have to memorize because you get question which surgery falls in which group, which is restrictive, which is malabsorptive. This only image, it is obsolete surgery, not done anymore. But maybe an image shown what surgery is this. You apply a staple and make a stomach very small. This is called vertical band gastroplasty, not preferred now, so you can skip. This is band gastroplasty, easily reversible. Best part, easily reversible. So this is important, and band migration is the most common side effect. And in band gastroplasty, the angle of band, this is the band with vertical line, is called phi angle. This should be 45 degree. Like these two x-rays, this one, the angle should have been here, 45 degree. It's obtuse angle with vertical line. This one as well, I can see the O, these are migrated band. So migration, band migration is the most common complication. And this you can very well know by x-rays only with phi angle. What is phi angle? Phi angle is the angle of band with the vertical line. This is the most commonly done bariatric surgery. Some book may say Roux-en-Y gastric bypass. No. In India, this is at least 60%, 70% we do sleeve gastrectomy. What you do? You remove 70% of the greater curvature. Ghrelin also becomes less, so hunger is also less. Points to remember, size of sleeve 32 French, and main side effect, the angle of his becomes distorted and string fibers are cut, reflux. So these are the points. Sleeve gastrectomy is an important surgery for you, most commonly done surgery. Roux-en-Y gastric bypass, simply cut the stomach, make a small pouch like here. Make a small pouch of the stomach and make a Y. This limb from here to here is called Roux limb. The length of Roux limb should be 100 to 150 centimeter. What is Patterson hernia? The most common complication. This is an important point you need to remember. Patterson hernia is hernia behind the Roux limb. And this is the most common complication, plus gangrene risk is very high. So it should not be delayed, should not go first. You have a question where there's a risk of history of hernia or obstruction, vomiting after this surgery after 2-3 months. Don't order barium, don't order CT, don't do endoscopy, immediate laparoscopy. So this should be followed up by, when you suspect this, order laparoscopy, diagnose and treat. Don't wait, don't delay. Gangrene risk is very high in Patterson hernia. Bilio band diversion is an obsolete surgery. In this surgery, how to differentiate this from this, I'll tell you. 3 Roux-en-Y surgeries we do. If you find normal stomach, this is Roux-en-Y gastric bypass. With Roux-en-Y, if you find dysgastrectomy, this is bilio-pancreas diversion. And if you find sleeve gastrectomy, this is duodenal switch. This surgery is called duodenal switch, where you have sleeve gastrectomy. This surgery is called bilio-pancreatic diversion, where you have distal gastrectomy. And this is called Roux-en-Y gastric bypass, which is the very, very important surgery. This is the most accepted surgery among all. So if you see Roux-en-Y and they ask what it is, then you simply see whether the stomach is there or not. If the stomach is there, then this is Roux-en-Y gastric bypass. If the stomach is gone, this is bilio-pancreatic diversion. If sleeve gastrectomy has been done with Roux-en-Y, this is duodenal switch. This sometimes we do, this is very commonly done, this is never done, and most common is sleeve gastrectomy. Okay? The last part, some triads of GIT, I'll just quickly go through them. Carnate triad, this is a very important triad. Remember this? Gist, paraganglioma, and this is pulmonary chondroma. Not pulmonary chondroma as given misprinting in some guide. Pulmonary chondroma, not chordoma. Okay? Meckler's triad is a Boerhaave syndrome. Boerhaave is spontaneous tear of esophagus, which is retching, vomiting, pain, and emphysema. Borchardt triad is volvulus, pain, retching. No vomiting. This is very important. In Borchardt, there is no vomiting, only pain and retching. And you cannot pass your Ryle's tube. Murphy's triad is very basic triad of MBBS, appendicitis, pain. And here also vomiting should always be written after pain. Never say vomiting, then pain. First pain, then vomiting. This is a rule. Vomiting should follow pain. Vomiting should never precede pain in appendicitis. So first pain, then vomiting. Charcot's triad, pain, fever, jaundice. Quincke's triad. Quincke's triad is a child of hemophilia. What is the most common cause of hemophilia? Can you tell me? No, not gallstone. How gallstone causes hemophilia? Yes, not ERCP. Okay, that's not hemophilia. It should come from liver. ERCP is caused, but no. What is hemophilia? Blood in bile. And what is bilhemia? Bile in blood. Blood in bile is hemophilia. Bilhemia is bile in blood. So most common cause of hemophilia is iatrogenic. In iatrogenic ERCP, if someone has thought it's fine, but no, that's not the correct answer. We have to do a liver pathology, liver biopsy, and something, PTC, something liver pathology. It should come from the liver. So hemophilia iatrogenic. Presents with pain, jaundice, and melena. If blood is small, causing occult bleeding, then Guyac test. Guyac test is for occult blood. So either it will say Goyak test positive or pain jaundice melena. This is Quincke's triad. Telox triad, this Telox triad was asked last year in UPSC and 2 years back in NEET. This is for mesenteric cyst, okay? Mid-abdominal swelling, mobile only in one direction, at right angle of root of mesentery, and a resonance in front of it. This triad are basically liver gallbladder. Dr. Gaurav will discuss this. So gallstone, diverticulosis, and hypertension are Saint's triad, hypoglycemic attack, sugar, and blood administration. So this is a last slide, and this is just a small suggestion to all of you. This is, this is not a time for complacence. You all, I know, are hardworking. And this is the time when you have to put in all of your efforts. So another few months, and definitely you will relish this time later on. So all the best to all of you. Thank you.